the co-executive director of the Stanford Medicine Center for Improvement and the chief quality officer at the Children's Hospital. And it's my pleasure to be the host today for the Stanford Medicine Center for Improvement lecture series. And we are privileged today to have Dr. Mark McGovern speaking with us today, and he's going to speak out about implementation science, some basics and cutting edge advances. Dr. McGovern is a professor of psychiatry and the behavioral sciences. He is the co-chief of the Division of Public Mental Health and Population Science. He has been a continuously funded NIH researcher since 2004 and obviously had multiple grants, and many of them with national implications. He is also the co-founder of the Stanford University Network for Dissemination and Implementation Research. So it's great to have him here to talk about implementation science today. Dr. McGovern.
Lane, thank you for the introduction, and of course, thank you for inviting me to present to this group. Thank you all for coming out on a near holiday break. I realize that this is adding to your probably frenzy of trying to get a lot of things done before hopefully you get some time to recharge and relax. So I'm going to take a chance and share my screen and see what happens. All right, well, that looks pretty good. All right, excellent. So I'd like to talk about implementation science, which I think some people feel could be an oxymoron, but there actually is a science to implementation. It's a newer science, and I think as time has gone on, it's become increasingly rigorous. And I'd like to share some of what we know and some of what we don't know. One of the things that I thought I would mention first is the distinctions between implementation and improvement science. And I'll go through this slide pretty quickly. I think the slides will be available through the Stanford Medicine Center for Improvement website. I think the most important thing is that although there are some differences between improvement science and implementation science, historical foundations, terminology, immediate objectives, even in methodology, when conducted using the state-of-the-art methods, particularly methods from implementation science, there's a lot of overlap. And I think we all want greater standardization to bridge between context-specific knowledge, which would be improvement science, and generalizable knowledge, which would be implementation science. Here's a rather busy table which conveys some of the distinction between quality improvement and implementation science. In improvement, we often focus on closing a quality gap. It's problem-driven. We have SMART goals. We have drivers. We have PDSAs and quick measures. We may or may not do things that lead to sustainable change. We ultimately aim to develop posters and case study type publications, but really I think what we ultimately want to do is change the healthcare system, change the healthcare setting in which we find ourselves. In implementation science, the goals are much grander. We want to close an implementation gap at a much larger scale. We want to usually bring in theory and models and standardized measures that are potentially generalizable. The goals in terms of career are often publications and grants. And again, it may or may not lead to sustainable change. That's a different question. One of the really other important distinctions, I think, is convening a multidisciplinary team at a local level in quality improvement. So all the key players are brought together, and usually the person leading the project is a member of the team, or at least works in the setting. In implementation science, it's often a researcher from somewhere else who comes in and may or may not do a good job of engaging the people who are actually going to be delivering the intervention. And even surprisingly, there are many implementation research projects where the key stakeholders are actually minimally involved. My sense is that those typically don't work out all that well. This is a little bit of a dialogue, and I need to credit my colleague Brian Mittman for this slide. What the implementation scientists say about quality improvement and what the quality improvement or improvement science people say about implementation. As you can see, it kind of goes back and forth, mostly around the idea of generalizable knowledge and the limits to being able to do things that cut across context. And the implementation science criticism is often really, how do you understand what you found, and will what you found actually have an impact? So the same, a lot of the same goals, but sometimes different perspectives on how the work should be done. If many of you are wondering what kind of work you want to do, and I know I do a little bit of both, but if quality improvement, you're a clinician, you care about the setting you work in, you want to make a change for the better, you're working at a local level, your approach is iterative, and you refine based on outcomes. If you're interested in implementation science, you might care more about theory, about scientific journals. You might care more about the rigor in measurement and causal inference. Many of you have probably seen this. This is the research to practice gap. This is a paper by Green et al. This is where it takes 17 years to get 14% of discoveries into actual practice, which is pretty unimpressive. It's pretty tragic. So even if we know something works, we know what to do. We often don't do what we know. I love this cartoon. My question is, are we making an impact? Are we howling at the moon? And is science really making the impact at a public health level that it could? And the answer is probably not quite. I want to shift now to some basics of implementation science. This is a classic textbook. It's now, this is the second edition, which is 2018. The third edition is in the works. I don't always recommend a book. I think, in many of our fields, you get the cutting edge information from scientific journal articles, but I have to say that this is a fantastic basic text. It's an edited text, so the chapters are written by leaders in the field, and it really covers the gamut across all of healthcare and just about everything you would need to know to be abreast of current thinking in D&I science. There's also a couple of journals, a journal Implementation Science, capital I, capital S, Implementation Science Communications, and those are the two leading journals that are available to really kind of get you up to speed with current work. Just some terminology. Again, this is really basic. The difference between diffusion, which is really a passive approach to get things out there. If I write a book or I develop a manual, maybe even a guideline, oftentimes diffusion is the approach to get it out there. Dissemination is a little bit more targeted, a little bit more active. There's much less known about dissemination strategies, dissemination science, than there is implementation science. Implementation is the active process of putting to use or integrating interventions into a setting or system. And sustainment is being able to continue maintaining that implementation beyond a more active implementation period. An active implementation period sometimes could be 6 months, it could be 12 months. Most people use the interval of 2 years. Does the thing you implement, is it surviving after 2 years? I'm not sure where the 2 years comes from, but 2 years seems to be kind of a standard cut point for sustainment. I put an asterisk next to evidence-based interventions because sometimes you don't know if your intervention or your guideline or your program is evidence-based or device. So really, if you don't have that kind of evidence, the kind of work, at least from a research perspective, that you do might change how you design the project to study. So for instance, if you have an intervention that has a strong degree of evidence, systematic reviews, meta-analyses, wide range of populations and settings, you can do an implementation study. If your intervention is less well established in terms of an evidence base, your project probably needs to include an effectiveness component. My colleague, Jeff Curran from the University of Arkansas, was the first to advance what are known as hybrid effectiveness implementation projects. I'm sorry, I have this transposed here. It's hybrid effectiveness implementation approaches where type 1 is much more effectiveness oriented. Type 3 is much more implementation outcome oriented, and hybrid type 2 sort of equally balances effectiveness and implementation. D&I science, and there's no formal kind of criterion or competence or license or certification that determines whether a person can or cannot call themselves an implementation scientist. I think some folks are thinking about trying to work on that, but so far not in that book. But it can really see that it's really the scientific study of methods to get things into play, to get things into routine care. There's a really nice article by Mark Bauer on the introduction to implementation science for the non-specialists. It's a fairly brief paper in the BMC Psychology Journal, and I think it's a really simple read if you want to check that one out. If you're new to D&I science, and even if you're not all that new, you'll hear a lot of talk about frameworks. What are implementation science frameworks? And it's a little bit like a theory or a model when you're conversing with D&I scientists and part of the group. In fact, there's a major national meeting this week, the D&I Academy typically in Washington. It's now entirely virtual. But it's really, these frameworks are the beginnings and basis for the rigor and reproducibility. And also, for those of you that are interested in publishing in the implementation related journals or in getting NIH grants, there's a study section specifically dedicated to dissemination and implementation science. The one that I've been a part of is called The Science of Implementation in Health and Healthcare, the trans NIH study section. But there's a fantastic overview paper by Per Nielsen, Per Nielsen, 2015 in the journal Implementation Science, where he delineates three kind of meta frameworks: determinant frameworks, process frameworks, and evaluative frameworks. And these are really important distinctions. I can tell you from being part of a study section that oftentimes if frameworks are misapplied, it's kind of a red flag that the person is not particularly knowledgeable in D&I science as an investigator. So we see this also in K applications, particularly in the proposed study. So this is from one of my sort of a classic movie, John Huston's Treasure of the Sierra Madre. Badges, we ain't got no badges. We don't need no stinking badges. It's a really wonderful film, black and white, Humphrey Bogart, John Huston, director, classic old time Western, if you like that kind of thing. But it's also quite an amusing line. So I've heard the same thing about frameworks. Mark, we don't want no framework. We don't need no stinking frameworks. Why do we need a framework? And I don't know, you may not need a framework, in improvement work, but I can tell you that it does help think about the outcomes. It does help think about the causes. It does help think about, the potential things that could make or break your improvement project or your implementation project. Then I'll start with evaluative frameworks. And this is really about measuring implementation outcomes. And the best known one is Russ Glasgow's RE-AIM framework, reach, effectiveness, adoption, implementation, and maintenance. And these typically, the reach, adoption outcomes are probably the most common and often measured in terms of proportion, and reach being the patients who need it or want it, get it, over all the patients who are eligible to receive it. So it's usually a proportion. And hopefully at the beginning of a project, you have a baseline measure of reach. Proportion, let's say, is 10% get it that need it. And let's say you get to 80% as a result of your project. After 2 years and maybe beyond that, you continue to find 80% continue to get the intervention, the desired intervention over time. Adoption is the number of providers who are eligible to deliver it, are actually delivering it. We're doing some projects across the state of California in emergency departments, helping patients who overdose get the treatment medications for opioid use disorder. And we're looking at the number of emergency medicine providers in the emergency room who are eligible to offer buprenorphine in particular. And the numerator is all of the providers that are actually offering it, emergency medicine docs. So implementation and maintenance are also, implementation is often a measure of adherence or fidelity to the intervention, the quality. And again, maintenance is very much like the sustainment, and effectiveness, of course, does the thing work. Determinant frameworks are really the mediators and moderators of outcome, and this is where context comes into play. So everything from the community, the patients, the service system, the health system, the clinic, the OR, all the people that work in the environment, as well as the characteristics of the intervention itself and the different things that you might do to foster the implementation. And the better known, one of the better known determinant frameworks is called the CFIR, C-F-I-R, advanced by Laura Damschroeder in Michigan, Consolidated Framework for Implementation Research. It's really been, after several reviews, been seen as the one that's most, lends itself most to research. And CFIR we've used, and it offers a nice inventory of contextual determinants. Process frameworks are really about stages and phases. The best known one is called the EPIS, exploration, preparation, action, and sustainment. Gregory Ahrens from University of California, San Diego is the developer of this particular framework. It also, and I'm sharing examples of each of these frameworks on the Nielsen kind of meta framework line. There are other examples of each of these frameworks. I'm selecting ones that I think are the best known, and also the ones that could lend themselves best to measurement. The Ahrens framework is supported in particular by numerous psychometrically valid measures to assess provider perspectives, to assess patient perspectives, to assess perspectives about leadership, which it turns out, and I think this is true about improvement work as well as implementation work, the role of leadership is critical. And Ahrens distinguishes between leadership and champions, and it's really kind of excellent work. And I think it's a cornerstone. His work is kind of totemic in the field of D&I science. Implementation strategies, and interestingly, are a kind of a newer area of focus in D&I science. And these are the interventions of implementation, the methods or techniques we use to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And this is a real simple way of defining implementation strategies and distinguishing them from a few other things. So the intervention, practice, or innovation is the thing. Effective research looks at whether the thing works. Implementation research looks at how best to help people do the thing. Implementation strategies are the stuff we do to try to get these folks to do the thing. And main implementations are how much, how well people do the thing. So this is, again, my colleague, Jeff Curran, and has got a very simple paper on teaching dissemination and implementation science to non-specialists. And this is literally a cut and paste of the slide that he uses to make these distinctions. And it's really, really an important distinction. Much of the work I do that's NIH funded is in the area of addiction and the treatment of addiction. And I think here you can see, whoops, I didn't mean to do that. Here you can see that in typical effectiveness trials, and this is sort of the first tier, we have unproven interventions and we want to assess patient level outcomes. That's kind of a clinical trial. People get the intervention, people get a control condition. We want to look at outcomes. In my field, we look at substance use and functioning. Standard implementation research, or the kind of the more recent implementation research projects, take these proven interventions and look at patient level outcomes, but they also want to look at contextual determinants. What are the kind of things in the context that may mediate or moderate those patient level outcomes? You know, the degree of fidelity, the enthusiasm or motivation of the providers who are delivering the intervention, the way the intervention is paid for, the way patients may approach the intervention in terms of their attitudes and feelings about the intervention. Implementation outcomes may include some assessment of reach and adoption, the kind of things I mentioned earlier. And the second tier really kind of begins to get at some of the hybrid trials that I mentioned previously. The advanced implementation research paradigm opens up that final black box and really looks at the kind of strategies that are used to implement the thing. And the implementation strategies could be the procedures, could be how the strategies are adopted. What are the targets of the implementation strategies? What are you really trying to leverage? And then the cost of engaging in those strategies. Really nice paper by Nola Proctor. If you are tracking implementation strategies, and this could equally be true for improvement strategies, you might say, if we're doing an improvement project, what are we really doing to help the providers implement the thing or use the thing, or have all of our primary care clinics follow up on positive screens for depression? How do we help primary care providers do that? And if we have a strategy to facilitate that, can we document the strategy according to all of these different components? So I'm going to shift now to, and I put cutting edge advances strictly hearsay. These are my opinions. By actually the whole presentation is my opinion, I suppose. But in terms of cutting edge advances, this is not really an empirical part of what I'm going to share. But one of the things that's most that I'm finding most interesting is an attempt to measure contextual determinants so that we know what leadership involvement is. And we are able to evaluate leadership involvement in a way that's kind of systematic and across studies. Or we know what a good network is of other supportive providers who are also invested in our implementing an intervention. So there's movement to be able to measure contextual determinants in a way that's standardized and quantitative. Typically up to this point and through this point, much of the effort to understand context is done through qualitative research. And the qualitative research could be very sophisticated, using highly rigorous and potentially reproducible methodologies. But in general, the newer focus is on trying to develop quantitative approaches to assessing context, because otherwise the field is left with a series of case studies that are very context dependent. And as implementation science advances, we want to be able to use precision in measurement, which, as we know, measurement is the crucible of science. There's also, fortunately or unfortunately, quite an interest in health equity within the context of implementation. My colleague from Washington University in St. Louis, Enola Proctor, and I've quoted her here. She has said, "Where there is inequity, there is implementation failure." So how do we consider health equity within the context of our improvement, our implementation work? And one way that's usually applied, at least in research, is making sure our recruitment strategies are broad and representative, or if they're not, if our population does not include underrepresented minorities, we do special efforts to over-recruit. Is that enough? It's probably enough in the context of a grant proposal, but does it really matter in the context of implementation? So this health equity implementation framework by Eva Woodward describes many different ways to think about equity in the planning of a project, in the early execution of a project, how to involve people at all phases and multi-stakeholders to make sure that there are kind of efforts to and strategies to limit any disparity or inequity in the development and study and scale up of an intervention. And there's a relatively recent paper by Shelton et al., which is from Glasgow Shop, which really extends the work of the RE-AIM to think about measuring RE-AIM evaluative outcomes through an equity lens. So I think these are two really important efforts, and increasingly people are thinking about how to consider health equity within the context of clinical trials. And I'm assuming, and I know less about this, in improvement science. Precision implementation is really becoming increasingly sophisticated in choosing implementation strategies. Often the strategies that we use are one size fits all. All of our participants, all of our sites, all of our providers get exposed to what we have to offer, or in some cases we have a buffet of strategies we offer, and people can pick and choose what they want to achieve the desired outcomes. The field is getting much more specific about choosing implementation strategies based on some evidence, based on some phenotype, if you will, oftentimes from context. This is a study that we recently got funded through NIH or NIDA, the National Institute on Drug Abuse, where it's really a stepped care model, a stepped implementation model, where we basically used measurement-based implementation. I think this is probably pretty small. I mean, I can see it. I don't know if you can see it on your end, but we have 76 clinics that start the project, and they learn how to collect data, informing them about the degree to which they're achieving the implementation outcome. We offer a 2-day training, and then we might offer external facilitation, which is a coach or a mentor, or train someone within their site to be a champion who can also serve as an internal mentor. The interesting thing here is that everybody gets enhanced monitoring and feedback. In other words, they get the data, and it's possible that if they make the change immediately, that's all they need. It's like you have hypertension. Let's look at your diet, and if that's enough to control your blood pressure, maybe we're good to go. We'll continue to monitor it, but maybe you don't need to be started on an antihypertensive. If, however, you don't make the change, that's a point where you might have to start the medication, or it might be a recommendation. And at that point, maybe you respond, maybe you don't respond, maybe additional medications are added, maybe different medications are tried, long before you get to the cardiologist. So this is really analogous to that, where we're using a stepped approach to implementation based on targets. One of the other features of implementation science that's relatively on the cutting edge is the economics of implementation. So each of these steps increasingly cost more money. And we'd like to think that if people don't need as much implementation support to achieve the outcome, maybe they don't have to be involved in all of these other activities, which are costly both in time and resources. Lane mentioned this group, and I wanted to put a plug in for it. This is SUNDIR, which we don't want to define literally. SUNDIR means something else, but here it's an acronym for the Stanford University Network for Dissemination Implementation Research. It was co-developed by myself and some people in pediatrics, Lisa Chamberlain, Grace Lee, Steve Ash in medicine, Alex Sachs-Harris in surgery. And we now are about 35 people who gather every other month. It's kind of come if you can. 8:30 to 9:30 a.m. Every other Monday morning. I think it's been a nice informal grassroots network. We're not supported in any way by any department or school or funding. It's really voluntary. And I think there's value added. I know that people have that have been working on grants have found people to collaborate with and identified people that could serve as consultants or even co-investigators. If you're interested in this group, Hélène Chakran-Garneau, who's my colleague, is the person to contact and get on the listserv. All are welcome. I think there's a range of pretty experienced people to less experienced people. And again, I think it's agnostic in terms of specialty and department, trans-diagnostic in terms of the focus of implementation activities. So I think I've met my goal in terms of the time of presentation. Hopefully, we have some reasons for questions and discussion.
Thank you so much, Dr. McGovern. That was excellent. I'm always struck when I hear people talk about implementation science, as you referred to. Sometimes we think of those as two different groups of people, but I think there's so much that can be learned between the two groups. And obviously, even if you're working on a local improvement project, thinking about it through some of the frameworks that you discussed, I think is always helpful, and vice versa. So I guess I'll start off with a question. You mentioned SUNDIR, and thank you for doing that. There's actually, when you mentioned the people who were involved in starting, there's a lot of overlap between the leaders of that group and of this group, Stanford Medicine Center for Improvement. So do you think there are other ways that we should be interacting and sharing information and learning from each other?
Well, the answer to that is not no.
Yeah.
I think that the potential for overlap is enormous. And I think, we have a work group within the context of Stanford Medicine Center for Improvement, where many of these folks are based, and it's kind of the thinking about publications and grants coming out of the improvement work that's being done. I do think there is an opportunity, and again, there may be many people on this at this meeting who would be fantastic and well received at SUNDIR. So I think that would be really a useful resource for you. But I think really just sharing expertise. So I think if people are doing an improvement project and wondering about contexts that could, make or break your improvement project, think about, let's check into the CFR, and maybe some of the items in the CFR, the inventory, are things that we should consider either measuring or addressing. And then think about, if you are using a particular implementation strategy in your improvement work, what is it? And sometimes in improvement work, we don't pay too much attention to the implementation strategy. So really, I think take a look at some of these metrics and take a look at some of these frameworks to really begin to document what you're doing in improvement science. And my sense is that you'll find that you're probably already doing these things, but you've maybe not been as kind of systematic or methodical, and maybe, again, not using some of the same terminology. So I think, this group and SMCI leadership can really move the needle on improvement work so that it does occupy that sort of overlapping space with implementation science.
Great, thank you. We do have a few questions. The first one is, could you please elaborate on what is done in the realm of quantitative investigation of contextual factors?
Yeah, there's a few things. I referenced Greg Ahrens's work, which is really survey driven, really trying to get surveys out to, key stakeholders and participants. The consolidated framework for implementation research, there are some efforts to use quantitative methods to rate the different elements of the CFR. We've been using what we call the CFR index, which involves key informant interviews, a site visit, and use ratings for on a 5-point scale from barrier to facilitator. In other words, is this particular item, let's say leadership investment, a barrier, which we would give a -2, or do we have a strong leader who's very invested in the project, would be a +2. So really trying to operationalize the CFR constructs into things that are measurable and potentially replicable, and certainly studied within the context as mediators or moderators within an implementation trial. Two newer developments with the CFR, actually one comes out of work in the evaluation sciences unit that Steve Ash leads. Nadia Safanelli is one of the investigators there, has identified a gap in the CFR, which is kind of glaring in retrospect, and that is the patient perspective. To what extent is the patient perspective of the new intervention a barrier or facilitator? Is it hard? Is it painful? Is it burdensome? Is it scary? How is it packaged? How is it labeled? So really the kind of things you might think of in terms of user-centered design are really a newer element to the CFR. And I think we can thank some Stanford folks for adding that. And Nadia is actually part of a panel at this D&I meeting this week with Laura Damschroeder describing this kind of newer, it's so old, it's new, right? This newer dimension, the patient level perspective. So I think those are the two things that I can speak to personally. There are other efforts to incorporate some of the health equity elements into each of those levels of context as well. So at the community or systems level, potential for access disparity at the organizational level, to what extent are all groups able to access the intervention, and even at a provider level, to what extent are all providers offering an intervention to individuals without a focus on any inequity. So I think those are that's my best answer to that question, but there are many other examples.
Great, thank you. Someone else asked, is there ever a time implementation science is not the appropriate approach?
No. Of course, I think, when something is really context specific, and you really want to solve a very local problem, you have no interest in advancing it, beyond the immediate solution, then I would think you probably want to keep it simple and do your basic A3 improvement, quality improvement approach.
Let me ask you something else, Mark. So I always find it fascinating as to when people are successful at something, how they ended up there historically in their career path. And I'm curious to can you tell us a little bit about your path to becoming an implementation scientist?
Yeah, no, that's a great question. So I started out as a clinician, seeing patients back to back, and ended up getting a position at a research center at Dartmouth in the Department of Psychiatry, and launched on a career developing interventions for patients with comorbid substance use and post-traumatic stress disorder. And worked with other investigators at Dartmouth, got a K awards that some of you are familiar. These are career development awards. And I was a person transitioning from a clinician to a researcher. And K is a 5-year award that covers 75% of your time. The institution has to make a commitment to the other 25%, which Dartmouth more or less did. And I used that time to develop an intervention, a behavioral intervention for patients with comorbid PTSD and substance use disorders, and obtained a couple of R01s after that K, investigating the same intervention and advancing it through stages of behavioral treatment development, from safety and practicality to efficacy to effectiveness, and reached the implementation phase, and spent a great deal of time disseminating the intervention, training, consulting with health systems, with organizations, with providers on how to implement the intervention. Was working with colleagues who were also intervention developers, and we failed. We failed miserably, despite our best efforts, despite getting paid for consultant fees quite handsomely. Despite, I think, sometimes the best intentions of the sites who are taking on these interventions, we failed miserably. And we realized, I think, as a group, that there was this newer science called implementation science that we were tuning into. So I think, Lane, to answer your question, I got into this through a result of absolute failure, knowing that we had interventions that were better than what were currently available, but we, for whatever reason, just couldn't put them into play. And we thought that if there is a science about how to do that, we want to know about it, and we want to learn how to apply it. And together, this group put together a book, pretty simple book of checklists, the kind of things that you might think about if you're implementing. And then, and this was probably maybe 10 years ago, gradually the field of D&I began to evolve. Early on, it was very theoretical, very conceptual, very model framework based. And only recently, I would say over the past 5 years, been increasingly rigorous in terms of measures and methods. And, as someone who joined the party early, I think, I got perceived as someone who was a D&I scientist, so got involved in the journals and the study sections and the training institutes. And so it's been nice to see the field expand. We still have a capacity problem, which I think is a sub goal of SUNDIR, to help newer investigators and other investigators who are transitioning to the work, really kind of take it on. It's fantastic. I think the beauty of the work is that at the end of the day, we know it's about getting the best care possible to the people who need it most. So in that way, it's very rewarding. And I know colleagues that are researchers that don't think too much about, the scale up of their work or the implementation of their work. They're interested in effectiveness and, getting the results published and getting the next grant. But I think our goals are really toward public health. And to me, that's really, that feels good. It's work that's good. It's good work and work that's good, I guess I should say.
Okay, great. We have probably 4 more minutes. We do have 2 other questions that have come in. The next one I'll go to is from Grace, actually, and it's, what suggestions do you have for how to better embed implementation science into health systems thinking, and what are the opportunities and barriers?
Yeah, well, someone like Grace embodies it. I think you have people that know a little bit about D&I science involved in improvement work, involved in training of people doing improvement work. I think the Lucille Packard quality improvement effort, through Grace's leadership and Kate Steffen's leadership, really is D&I informed and uses D&I science to, to think about harmonizing knowledge across projects. So I think that's really beautiful work. Of course, leadership, it's important that leadership of health systems, embrace D&I science. We did a review paper of projects funded in the D&I science space in our particular institute of interest, the National Institute on Drug Abuse, and we found that less than 4% of projects were kind of at the implementation phase of things. The investment in D&I science remains fairly small, relative to the overall biomedical research budget. Yet it could be critical to have things, have a science developed on how to implement things. I'm not going to say equal to the science of discovering things, but it should be larger than less than 4%.
Okay, let me go to the next question. This one says, many improvement projects implement without using the term implementation. Instead, we like to sustain our interventions. You cannot sustain without implementation. How important is it for us to change that mindset?
Could you read that again? I got lost.
Sure. Many improvement projects implement without using the term implementation. Instead, we like to, quote, sustain our interventions. You cannot sustain without implementation. And how important is it to change the mindset?
Yeah, okay, I think I have it now. So I think sometimes in that Jeff Curran, pretty pithy slide about the thing would really help here. So sometimes we use the term implement as a verb. And the kind of work that we've been talking about today is kind of implementation with, I'll just say a capital I, where the focus is really on what you do to install or sustain the thing. So that's the first part. So really understanding what you did to make it happen, or what you're doing to make it happen, and try to document that and understand that, because you might need to do it again in some other place, or you might need to do it, you might need to write it up, or you might want to write it up so that others in other health systems and locations could learn about how they might do it and implement that thing. So I think being able to use that experience and document that experience is really important, not only for the potential to sustain it, because you might learn what worked and what didn't work. I mean, there's also implementation failure. There's a lot of things that we do that don't tend to work out, and it would be equally good to know about those as well. So you begin to develop a kind of a track record, or a way of understanding what implementation strategies that you used worked, so that they're potentially generalizable, so that you could use them the next time, and that you might be able to figure out how to improve or refine or make your own work more efficient. I think that was the question. I hope that answered it.
Thank you. And I'm going to do one last question. This is the final one. Are you ready? It says, one of the challenges in implementing a promising practice from an original site and then spreading it from one site to another is balancing fidelity with customizing the intervention to the local context. Could you please provide an example of where this balance is achieved using the framework to facilitate the spread implementation of the promising practice?
Yeah, that's a really good question. We have a colleague here at Stanford, Shannon Wiltsey Sturman, who's a psychologist based in the VA, who's actually written extensively on balancing fidelity and adaptation. So I would encourage you to be able to contact her. She's really the kind of at the forefront of making distinctions between terms like modification and adaptation. But I think the idea here is that, and it makes sense that if you have an intervention, you want to deliver it as closely as possible to design, so that you get the outcomes that were originally produced when it was studied more carefully for effectiveness. Yet, you want to be able to adapt it to fit your situation so that it fits and it's not it's less acceptable. So sometimes people who are intervention developers are the hardest ones to convince that their interventions can be adapted. But most intervention developers are keen on what are the core concepts, what are the key ingredients that need to be present in any adaptation. So if there is an adaptation, at least those 2 or 3 things or 4 things need to be held in place. But I think it's a great question, and I don't think every intervention needs to be adapted as much as sometimes folks think. But if you do adapt it, you might need to study the outcomes so that you preserve the effectiveness that were found in the original version of the intervention, let's say.
All right. Thank you so much, Dr. McGovern. This was a great presentation, and thank you for answering everybody's questions. Thank you to all for joining us today. And Lisa, any other announcements before we stop?
Just some folks were asking how to get a hold of Shannon, and we will get her information from Mark, and we'll post that with his slides and the recording of this talk in a few weeks.
All right. Thank you so much again, everybody. Everybody have a great afternoon. Take care.